in interventional radiology presented by SYLVAIN GRANGE from France. It's a video recorded presentation.
Hello everybody, I'm very glad to be here. My name is Radiology. I come from France in the University Hospital of Saint-Étienne. So this is the overview of my presentation. In introduction, I have to begin to say that the prevalence of cancer is increasing for all stages, and pain is often present in half of the cases. And analgesics are sometimes limited effectiveness, and there are side effects and addiction. Interventional radiology techniques are becoming more varied and more minimally invasive, and invasiveness of the procedure and rehabilitation time to be adapted according to the vital prognosis and fragility of patients. In collaboration with several doctors involved in cancer care in a multidisciplinary meeting, and the radiologist must be at the center of the management of cancer patient pains. For consultation and follow-up are very important. Before the intervention, we have to get a reflection on the modality of guidance, marsupial, ballistics, and the anesthesia method. We have to look for contraindication or risk of complications. We have to assess the pain with numeric pain rating scale, quality of life, physical activities, treatment efficacy, exploration of recent imaging study. The explanation to the patient are very important about guidance methods, management circuit, anesthesia mode, expected benefits of the procedure, most frequent as the most serious risk, and answer to questions, documents to be given, and trustworthy person. And we have to prevent and manage the pain related to the higher procedure. After the intervention, in general 1 month after the procedure, we have to check the skin condition, make an evaluation of pain thanks to a numeric pain rating scale to evaluate the quality of life and physical activity. And if necessary, the prescription of physical therapy, review with the patients or the doctors. And it's very important to send reports to the patient, the treating physician, and the prescribing physician. So techniques and clinical case studies. So first one, cementoplasties. The objectives of the cementoplasty are analgesic, but it's also stabilization of a fracture, pathological or porotic one, and prevention of the onset of or aggravation of a fracture. The technical principle of the cementoplasty are quite easy. We inject cement into the fracture and into the pathological bone through percutaneously placed trocars under imaging control, in general scopy and CT, or scopy and CBCT, or just only scopy, only with scopy. And the localization are on vertebrae, pelvic and long bone tumor like humerus and femur. Here is a case of a 73-year-old patient with a metastatic rotator neoplasia, and this patient have pain at the dorsolumbar hinge, and you can see here the fracture lytic lesion of L1. The cementoplasty of L1 is performed here under local anesthesia, and you can see here the radio-opaque cement in the vertebrae. There is a possibility of cementing several vertebrae during the same procedure, in general under general anesthesia, as you can see here. So the next step is the screw fixation and cemented spindles. So why screws? Why screws? First, we have to know that cementoplasty only resists to compression forces, like in spine, but not to torsion forces, like in pelvis or femoral neck, where there is tension forces, bending, torsion, shear, etc. You know that metastatic patients are often ineligible for major surgery because surgical or anesthesia contraindication, rehabilitation time after surgery, and a very important point is the impossibility of postponing general cancer treatment because the healing period after surgery. There is important consequences of bone metastases, especially fracture. And in the last years, there was a lot of technical improvement of minimally invasive CT or CBCT procedures, and there is involvement of the interventional radiologists in oncology management. So in the last years, there is a development of the combination of minimally invasive osteosynthesis percutaneously and cementoplasty. You can see here fully or partially threaded screws. So what's the material for fixation with internal cemented screw? As for cementoplasty, you need a trocar, hammer, and cement. For screwing, you need more AG trocar, a Kirchner wire, and you need screws. It's not you need a screwdriver. It's not very complicated. So here is the first case of a 60-year-old woman with a breast cancer metastases with left inguinal fall pain, difficulty walking. And you can see here a fracture of the femoral neck on a lytic bone metastatic lesion. We inserted 3 screws throughout the femoral neck and head, and after we have injected semen in the fracture, in the lesion, and throughout the screw. This procedure improves the quality of life from 25 to 55 out of 100. The pain decreased from 10 to 4 out of 10. There was disappearance of waking up at night. Morphine doses were divided by 2. The patient rise on day 2, work without work on day 5, and return home at day 6. The resumption of chemotherapy the day after the intervention. This is a very important point because there is no need for healing time, and the patient was able to quickly resume driving and activity of daily living. Another case with fixations of the sternum by internal cemented screw on a 68-year-old patient with a very painful fracture sternal metastasis. As you can see here on the 3 planes on CT, you can see the lesion and the fracture. So first we insert Kirchner wire throughout the fracture and the lesion into the sternum. After we insert, thanks to the screwdriver, the screw with CT and scopic guidance. This is the screw in coronal view, and after we inject cement through our trocars. And you see here the cement in the lesion, in the fracture, and around the screw. Another example with the fixation of the odontoid process by internal cemented screw in a 62-year-old patient with a breast cancer with a very painful fracture C2 metastasis. You see here the lesion with the fracture of C2. We first perform enhanced CT to visualize the jugular-carotid vessels. After we insert 22 G needle to inject diluted contrast media in order to put backward the vessels. After we, under CT, we put the Kirchner wire until the odontoid process, thanks to scopic and CT guidance. And after we insert the screw in the odontoid process, and after we inject cement around the screw. And at you can see just one suture at the end of the interventions. Spindles, it's between cementoplasty alone and cemented screw. Spindles are injected inside. Directly inside the trocar after a little injection of cement, and thanks to the bone filler, we can carefully push the spindle and the cement and remove the trocar in order to just let in place the spindle and the cement. Thermoablations, you know that thermoablations consist in destruction of a tissue or tumor by heat, radiofrequency or microwave, or by cold like cryotherapy. You can see here an example of monometastatic terine neoplasia with a bone lesion on T12 and a collegial decision. In collegial decision, we perform to cryoablation for curative purpose. We have to be careful to the esophagus, the spinal cord, and the foramen, and we put the cryotherapy needle throughout bone trocar. And at the posterior part, just near the spinal cord, we put thermometers in order to control the temperature just near the spinal cord. And you see in the MRI control of the tumor without injury around. Embolization. The goals of embolization are to reduce the vascularization of the tumor by injection of microparticule in general, or glue or something else, after selective arterial approach of the arterial vasculature. It can be performed under local anesthesia, and the objective are to limit the risk of hemorrhage during the peri-intervention. The intervention can be performed by surgeon or interventional radiologist. And the other goal is to control the tumor. Here is an example of a 41-year-old woman with a kidney cancer with a painful metastasis on the distal clavicle. The lesion is very vascularized, as you can see on CT and MRI. And after embolization, the surgeon make an intervention without the risk of hemorrhage. Combined procedures, it's very important because the interventional radiologist can perform several procedures in the same times. So this is an example of a 69-year-old patient with left sacral pain in a history of metastatic renal neoplasia, so with the high three-stroke hemorrhage. So we first perform an embolization after a biopsy, which is very important for oncologists, for immunotherapy, for example, after cryotherapy, and after we inserted 2 screws by a transsacroiliac approach, and after we inject the cement into the lesion. A word on chordotomy. Chordotomy consists on the destruction of the contralateral spinothalamic bundle for analgesic purpose. In case of resistance of morphine analgesic and in the context of metastatic neoplasia or sarcoma. It has to be done on vigilant anesthesia. This is a very important point because sensory and motor tests are needed before treatment. There are 2 possibilities, the surgical way for thoracic level and radiological way for cervical level. Here the patient is a 30-year-old woman with a right arm sarcoma with intractable pain in the right upper extremity. Here is the interventional CT room with the CT, the scopic, and the impedance metric measure. So the guidance is quadruple by scopic, CT, impedance metric, and clinical, because the procedure is performed under vigil anesthesia. So after Miro CT, we put the 20G needle inside the spinal cord at the cervical, at the C2 level. And after a clinical test, we eat during 1 minute. And this is the MRI the day after the intervention with the diffusion inside the lesions and edema around the scar. And the patient had a complete disappearance of pain in the right upper limb the day after the interventions, and the benefits were maintained thereafter, and without motor deficit. So in conclusion, there is a high interest of close cooperations between the interventional radiologist and all the specialists involved in carcel patient pain management, and the assist of the radiologist in the multidisciplinary consultation meeting in the management of the metastatic bone patients are the diagnosis, because we are all diagnostic radiologists before to be interventional. We can make biopsy. We can make combined procedure in one time, in one anesthesia, and the minimally invasive character of the procedures. Thank you for your attention. Merci beaucoup. Shukran.